our other last-minute speaker is not a neurosurgeon. He's a medical oncologist, Dr. Jim Whittle, and one of the reasons that I've asked him to speak is who becomes confused at how the histopathology or molecular data about our patients' tumours, who comes confused about what that should mean for further management? Everyone, there's a few people agreeing. Come on, anyone become confused? Yes, someone up the back. So Jim is the person who can always explain to me what the WHO classification and the molecular characteristics mean for our patients' management, and that's why I've asked him to speak. So thanks, Jim.
Thanks very much, Professor Drummond, for the invitation, and to the organisers. It's great to be with everyone online this morning, and was actually really exciting to listen to Matt's talk and your talk earlier about some of the advanced surgical techniques, which I have equally challenging times trying to explain to anyone. So as Professor Drummond introduced, I wanted to give a very high-level overview about how we think about classification and treatment for diffuse gliomas, and trying to make this as concise and as straightforward as possible. So the background here is that the classification for diffuse gliomas has evolved over the past 5 years to increasingly involve molecular characteristics, which is helping refine these diagnoses to help improve prognosis and treatment options. So as by way of introduction, this reference histology in the top panel here uses the old classification system: anaplastic astrocytoma, anaplastic oligodendroglioma, anaplastic astrocytomas. And through the addition of 3 markers, ATRX, 1p19q co-deletion, and IDH mutation status, we can refine the molecular diagnosis into 4 broad categories. And this, if you look at the Kaplan-Meier survival curve on the right, nicely breaks down these groups into their prognostic features. And as we know, the oligodendrogliomas having the best outcomes, followed by the astrocytomas and our GBMs here in green. So although that's sort of quite simple, the WHO 2021 classification system includes really hundreds of different diagnoses, which can be quite daunting given that a number of these are increasingly incorporating molecular tests to help define them. But in reality, in terms of the most of the work that we do, probably more than 90%, this glioma can really be classified into 2 major types based on the IDH status. And that is, our IDH mutant gliomas, which can be grade 2 to grade 4, or IDH wild type gliomas, which are all grade 4. Let's change this to a laser pointer. And the main update that has occurred since the 2016 classification system for the IDH mutant gliomas is the introduction of CDKN2A homozygous loss, which will upgrade a grade 2 to 3 to a grade 4 lesion, and essentially recommendations for treatment of this as per a GBM. And the other key update is for tumours which look low grade morphologically, but are IDH wild type, and have other features such as TERT promoter mutation, EGFR amplification, or chromosome changes with loss of 10 and gain of 7, are now upgraded to glioblastoma and treated as per that mechanism. Now, the other sort of key message I think that I wanted to give is that although molecular diagnoses are increasingly used in our clinical practice, most of these cases can be diagnosed with really 4 immunohistochemistry and FISH stains with quite ready use. And so if we take a glioma that comes through the pathology department, and the first test is to look at whether it's IDH mutated or wild type. And really, once we get a wild type case, we're almost certainly looking at a glioblastoma, with the caveat that for patients who are under the age of 54, we recommend doing sequencing for IDH1 and IDH2 to see if there's a non-canonical mutation, which may change both the prognosis and treatment options for that patient. And then for the IDH mutated category, these can go down two pathways, those that are 1p19q co-deleted and are diagnosed as oligodendrogliomas, either grade 2 to grade 3, depending on the morphology, or those that are 1p19q intact and have mutations in ATRX. The next question is, what is the CDKN2A status? And if it is lost, this is where we grade 4 astrocytomas now. And if CDKN2A is intact, grade 2 to 3 astrocytomas. And this is really the simplistic way that I go through in my mind when I'm looking at a report and thinking about the ultimate treatment options for the patient as well. So I wanted to go through each of those sort of key biomarkers in a little bit more detail and why they're important. IDH mutations, going back to medical school and the TCA cycle, we know that mutations in IDH1 lead to a production of this enzyme metabolite, alpha-ketoglutarate, which is then transformed into 2-hydroxyglutarate, which has a number of mechanisms, particularly with DNA hypermethylation, and ultimately promotes tumorigenesis. And the current thought is that the IDH mutation is the earliest tumorigenic event in these lower grade gliomas. As I mentioned on the previous slide, most of these can be detected on immunohistochemistry with the R132H stain, but for patients who are of a younger age, under 54, and a wild type on immunohistochemistry, we typically recommend sequencing for IDH1 and 2 to look for non-canonical mutations. And the key message in terms of the relevance of this for patients is that it's associated with an improved overall survival and response to treatment at all grades, whether it's grade 2, 3, or 4. And now with the emergence of treatments to directly target the IDH mutations, I think we're going to see a lot more evolution in the field here. The next key biomarker is looking for 1p19q co-deletion, which can be tested in a number of different ways, but classically using FISH. And you can see this shown in the figure on the left, where you're seeing loss of the 1p here, only 1 copy in the red compared to 2 copies of the green, and similarly of the 19, where you can see that we're seeing loss of the double copies here. Now, if we go back to some fairly old studies now, we know that co-deleted tumours have a much better prognosis and a much better treatment response. And it is probably the most powerful predictor of prognosis in patients with IDH mutated tumours. It remains interesting that although this is the pathognomic feature of oligodendroglioma, the biological significance of this still remains unclear and an ongoing area of work. The next biomarkers are the ATRX, T53, and TERT. And again, going back to medical school days, remembering that shortening of telomeres is associated with DNA damage and leads to cell cycle arrest. But cancers can really hijack this process and allow escape from senescence and lead to uncontrolled growth, which is the key feature of cancers. And in gliomas, there's 2 different mechanisms that this might occur. So we see TERT promoter mutations in glioblastoma and also in oligodendroglioma. And typically astrocytomas are characterized by mutations in ATRX. And this is often accompanied by TP53 mutations, which usually go hand in hand for this diagnosis. Next, CDKN2A, which is sort of the more recent introduction into the classification system, and loss of CDKN2A or B is an independent poor prognostic marker, where you can see in this Kaplan-Meier survival curve of astrocytomas. And this has now been incorporated into the classification system. So even a sort of very benign looking grade 2 lesion, if there is loss of CDKN2A, is upgraded to a grade 4. And our current practice now is to treat patients accordingly based on that biomarker. Now, often CDKN2A FISH or other sequencing options are not available within pathology departments, but there's a number of good surrogate immunohistochemistry stains. Some of these are just also used in our department at the Royal Melbourne Hospital, where looking for P16, loss on IHC correlates very nicely with CDKN2A loss, as you can see on the left panel. And then more recently, this protein called MTAP, if we see loss of this staining in the cytoplasm, this is control within the vessel, also correlates very nicely with fish. So even if you don't have ready access to fish and other tests, by doing these stains, you can get a very accurate representation of the tumour, which is quite meaningful in the treatment options for these patients. Now, for wild-type gliomas, there hasn't been as quite the same change here. We know that MGMT promoter methylation, remains the key prognostic marker for this group. Looking at the schematic on the left, when this is methylated, it essentially turns off this gene repair, and so there's no expression. And that's a good thing, because we won't want DNA repair when we're trying to treat patients with DNA damaging agents, both radiation and chemotherapy, when that's their role. And in the unmethylated group, there is still expression of MGMT, and so that allows it to repair DNA damage, and hence both radiation and chemotherapy is less beneficial. And the sort of seminal paper here, a reevaluation of the original Stupp paper from Monica Heggie and colleagues, where they looked at the methylated promoters having an improved survival compared to unmethylated. But clearly we need more biomarkers to emerge over time to help treatment options for patients. Just the final one to mention, I think, was the increasing acknowledgement of the role of H3 mutations in the diagnosis of diffuse midline gliomas in adults, but also in other tumours in children, and not to miss these important features. So you can see here there's an immunohistochemistry stain for H3K27M of a very classical looking midline tumour here on the left. These are predominantly astrocytic, characterized by H3K27M mutations, and are mutually exclusive with IDH1 mutations. And whilst they're predominantly seen in children, they are increasingly seen in adults. And again, this is quite relevant because of new treatment options emerging for this field. And just highlighting in the schematic below, there's not just H3K27M being the most sort of well-known and common alteration in these histones, but also G34R, which is associated with diffuse hemispheric high-grade gliomas, again, most commonly in children and AYA population. So I wanted to sort of briefly overview about how I use these biomarkers to guide treatment decisions when patients are referred to us post-operatively. And, I take a very sort of algorithmic approach, really, when patients are referred. So modifying from the NCCN guidelines, patient who presents with an MRI, which is consistent with a lower grade glioma, comes to see a surgeon, and whether there's an attempted macroscopic resection or biopsy subtotal resection. And we then make a risk assessment. Low risk, I would consider a patient who is under the age of 40, who's had a gross total resection or a very good resection, who is IDH1 or IDH2 mutated and has 1p19q co-deletion. And sort of balance that against the more intermediate risk group. So these are still typically IDH mutated or non-co-deleted, but have some other more adverse prognostic markers. And this can be older age, a neurological deficit, or persistent seizures, or who have large tumours and have had a subtotal resection. Now, this is relevant because I think particularly this low-risk population, we're very comfortable with recommending active surveillance for this group. We know that many patients will have multiple surgeries, and in particular, if further progression would be managed with further surgery, then we're keen to offer active surveillance in this group if there's not an appropriate clinical trial. Whereas the intermediate risk group are those patients who would typically recommend moving on to radiation and post-radiation chemotherapy based on the RTOG 9802 trial, which I'll give a high-level overview on the next slide. And then those who are the high risk. So these are the patients who you probably thought were going to be low grade based on the MRI, but we got it wrong because they're either IDH wild type, they've got CDKN2A loss, or the other molecular features of GBM that I mentioned earlier, the EGFR amplification, TERT promoter mutations, or gain of 7 and loss of 10. And typically, we would manage these patients as per a GBM, so with an EITC Stupp protocol chemoradiation. although I typically monitor them as you would for a high-grade glioma. So this is sort of something that we often mention in our MDT when we're reviewing these patients as well, and asking the question about when to initiate chemotherapy in low-grade glioma. And when I'm talking to our registrars and fellows, my basic mantra is, I think once therapy is recommended, so once post-operative therapy is recommended, then radiation and chemotherapy has an overall survival benefit. So I really explain it to our patients that this is a package deal. It's not radiation or chemo, but it's giving them together, which has the greatest benefit in long-term outcomes. And again, this is based on a very old study now, the RTOG 9802 trial, which looked at patients who were considered high risk low-grade glioma and using the old classification system. And this included people who were older than the age of 40 or who had subtotal resection or a few other features. And they received 54 gray of radiation and PCV or radiation alone. And what they showed was in the top bar, Kaplan-Meier survival curve is progression-free survival. Those who had radiation and chemotherapy had a marked improvement in survival, progression-free survival, compared to those who had radiation alone. And this was particularly so in the IDH mutated group, who had an overall survival of 13 versus 7.8 years, and significant improvement at 10 years as well. And these sorts of numbers are really striking if we think about a 5-year improvement in survival just by the sequencing of treatment. So this is not just because they got chemotherapy at all, because most of the patients in this trial who had radiation alone up front still received chemotherapy. It's really that giving the radiation, the chemotherapy as that package up front together is where you get the most benefit. Grade 3 astrocytomas, the old anaplastic astrocytomas, we really based treatment on the Catnon trial, where patients undergo maximal safe resection, followed by radiation to 60 gray, and then chemotherapy with 12 months of temozolomide showing an improvement in overall survival. Again, almost a 2-year improvement in survival by giving the chemotherapy in addition to the radiation. One question that, again, this is something that we often discuss at our tumour board in this group: should we give them concurrent chemotherapy with their radiation as well as the adjuvant? Now, in my mind, although there's only a trend to improvement in survival in this group, I think it's likely to mature in that there will still be a benefit of giving the concurrent chemotherapy with the radiation. And given that this does not add a great deal of toxicity, that is our current practice for these patients. And then finally, our grade 3 oligodendrogliomas, the old anaplastic oligodendrogliomas. This is, again, old data based on Martin van der Bent's work for a number of trials, and looked at radiation followed by adjuvant PCV chemotherapy, and showing the striking improvement in overall survival. And again, another 7-year gain by giving the adjuvant chemotherapy. So chemotherapy is really important for all of these IDH mutated gliomas. We know one thing, and this is a common discussion amongst neuro-oncologists and medical oncologists who look after brain tumor patients is, well, this trial used PCV, as did some of the others, but this is a very toxic regimen, and lomustine in particular, we're not sure about how much longer that's going to be accessible. So then a number of sort of issues that emerge on this age-old question in our field about temozolomide versus PCV. The first is that if we go to the evidence, most of these studies use PCV for the lower grade gliomas, but it's toxic, it's inconvenient, it requires a chemo day unit. And then there was also some worry about 5 years ago that temozolomide was going to drive hypermutation and actually cause malignant transformation of these lower grade gliomas, but that's subsequently debunked. And so I sort of take some sort of solace, and this is probably the only trial which has really compared PCV versus temozolomide in any sense in patients with anaplastic gliomas. And basically, the summary is that PCV was a little bit better for the 1p19q co-deleted tumours, but this was not statistically significant. So I think most of the purists out there might still use PCV. I think they're probably 10% of the community, but in our practice, we would use temozolomide because it's convenience and better tolerance.
Jim, we've got 1 minute.
final sort of thing to mention here will be to sort of obviously the biggest excitement in the 2023 in our field being the introduction of IDH inhibitors. So vorasidenib, which is a dual IDH1 and 2 inhibitor, showing in the red a significant delay into time to the next treatment intervention compared to placebo, which is clearly very meaningful in this group if we can delay their radiation and chemotherapy. And hopefully over the coming years, we'll be able to see an increasing access to these medications and make them more broadly available to the community. I think this will be a case of watch this space. So I'm going to flick through GBM because I don't think there's much to talk about here. And I think there's some ongoing questions in the standard of care. But the basic summary being that the updated WHO classification system incorporates molecular testing, although most diagnoses can be made on histology and immunohistochemistry. And understanding these biomarkers can influence survival and direct treatment approach. And thanks again for the opportunity to participate.